sorry to the 12 of you that were on the other Zoom. I will make my intro much shorter this time so you don't have to listen to me too much. And hello and welcome to the rest of you that are on here. And it looks like we should be all set. My name is Angela Wright. I am an emergency medicine and EMS physician at the University of Colorado Hospital, where I'm also the EMS medical director. I am really excited to be here tonight talking to you all about airway management. I'm going to turn my camera off to do my teaching just because I find it's more comfortable for everybody, and then I'm not staring into the all of the black boxes with names. So airway management, I'm gonna have to repeat myself a little bit because we did start this talk on a different Zoom, but now we're on the right Zoom. So airway management is not a checklist. We need to get checklists are really important in medicine, but we're going to get a little bit away from that here tonight because it's a continuous loop of assessment, intervention, and reassessment. If I were here to just teach you all how to intubate or how to do a crike, it'd be 20 minutes and 5 to 7 slides long. But what we're really going to do tonight is get away from this mentality and dive into the bigger picture. That's the management of the airway. And the management of the airway is a much more complex topic. Good providers, the best providers, don't just manage airways, they're going to anticipate airway problems before they ever happen. So rural EMS, which I recognize so many names on this Zoom here, as you all know, it adds such a layer of complexity. It adds distance and limited resources and no backup and long transports, and the demands are even higher on you all as rural EMS providers than they are on other EMS providers that are charged with what is a fairly challenging task. So we're going to reinforce tonight that the approach to the airway is more than just, pieces of plastic between the cords. It's comprehensive and it's really process driven through assessment. Um, Carrying forward, most airway failures in EMS are not equipment failures, they're assessment failures. It's because we missed a sign, we missed an indication that something was going south, we delayed a decision, or we stopped our reassessment. The airway doesn't fail all at once, and neither should your approach. You should be continuously assessing and reassessing, right? So, this is a dynamic process. That means as your patient changes, you need to change. This is a continuous process, meaning at no point in the call are you not thinking somewhere in your mind, or are you thinking that the airway is done, right? This is something you're always doing. And then from the rural context standpoint, in the ER, I have got respiratory therapists and ventilators and ICU doctors and other ER doctors and surgeons, right? 30 seconds away from me paging out or calling out a difficult airway. You guys are by yourselves at 2 a.m. in the middle of the road, and the helicopters can't fly because the ceiling's too low, right? So that demands really a higher standard of this ongoing assessment. For those of you that have heard me teach before, we always start with an anatomy and physiology review because you can't predict the abnormal unless you truly understand the normal. And then I'm going to teach all the way from, I'm going to teach from EMR to critical care paramedic in this talk, as I usually do. And don't stop listening if it doesn't apply to your certification or license level, right? Understanding the concepts and knowing how to best help your team and knowing when to call for help all play into the decisions you're going to be making. So we'll cover the assessment, and that's really, like I said, that's going to be the foundation that is driving your decisions. We'll go through basic adjuncts in BVM. We'll go through advanced airways, what to do with the failed airways, some special populations, and we'll do some scenarios at the end. Okay, so before we talk about any device or any intervention, you need to be able to visualize what it is that you are dealing with. And I truly want you to practice when you're assessing your patients what the anatomy is and understand the physiology before we make any decisions. You can't make decisions without understanding these things. And I'll kind of kick off each topic with a scenario. Sorry in advance, you're not going to get like conclusions to all these scenarios. We'll just say that like you did a great job and everybody lived and you saved everybody's lives. But these are more just ways to transport your mind into the clinical space than they are to truly give you like a complete lesson here on the scenario. So our first patient is a 58-year-old rancher who's found unresponsive in a field by a ranch hand. He has a GCS of 6 and no obvious trauma. Your closest hospital is 38 minutes away. So, what are you seeing and hearing and feeling before you even reach for anything? What anatomy are you going through in your head as you approach your patient? Really want you to start thinking about, what does unresponsive tell you? What does a GCS of 6 tell you? What does 38 minutes mean as far as the decision-making process on scene? All of these things that, should be going into that. So yes, exactly. Things that you're thinking about are that do they have a pulse and are they even breathing, right? So with a GCS of 6, we need to be thinking ahead of whether or not we're going to be running a cardiac arrest, right? So the upper airways, know your terrain. Know that your nose and mouth go to the nasopharynx, the oropharynx that lead to the hypopharynx, and then you have your tongue, which is the great obstructor of all airways, and your epiglottis, which is floppy and kind of the princess of the upper airway. So we like to think of the upper airways as straightforward and things we can see. It's just the nose and the mouth after all, right? Yeah, and it's absolutely essential, and it can lead to some of the sickest patients you will see when things go wrong in this area. So, soft tissue edema can close an airway in minutes, right? Burns, anaphylaxis, angioedema. So, as we walk through the upper airway, looking at this cross section, we have our nasal cavity, our hard palate, and our tongue. So, taking our first case, what sound do we hear when that tongue has fallen posteriorly? What sound is it that we're going to hear when the tongue is falling back into this purplish teal area? Yep, snoring respirations, right? Snoring respirations. Thank you guys for participating in the chat. It makes my job much more fun. So we're going to hear snoring respirations. We're going to have these concepts that are already starting to sink in, and we need to maybe open this airway. The upper airway is dynamic, right? It changes with the patient's position. It changes with muscle tone. It changes with secretions. It changes with different pathologies. These structures are floppy and they're flimsy and they're unpredictable. And the straight path for oxygen to get from the outside world to the inside world requires that these structures remain open. So what are some other signs of an upper airway obstruction that you can identify without a laryngoscope? We already said snoring. Stridor, yep. I saw a snot in there somewhere, which I think is a good point also. So visible secretions and the patient's positioning, gurgling, exactly. These are the things that are going to tell us something's going on in the upper airway. So back to our rancher, right? We're running through a wide range of differentials and approaches while we're en route to the call. We arrive on scene, the patient's lying supine. You note significantly noisy, loud breathing as you're approaching the patient. The ranch hand states there wasn't any trauma. The patient was walking through the field and then he found him here. So the point here is remembering how much information you can gather by just approaching your patient and by thinking of the anatomy. Start listening early. I know the world of EMS can be noisy and we can't always hear subtle sounds, right? But we want your approach and your assessment to start very early on. And I want you to feel confident in that assessment and the structures that could be causing the findings that you noted in your assessment. So once we've made it past the pharynx, we are entering the lower airways and the lower respiratory tract. And it's important to remember that when we're thinking about airway management, we're considering all of the relevant anatomy and physiology. So we have to consider oxygenation and ventilation as well. We remember that the lower airways, starting with the trachea, and then that branches into the main stem bronchi that are further going to subdivide into the bronchioles, and then finally the alveoli. And you can see here in this very nice picture the intricate connection of the alveoli with the arteries and the veins that allow for oxygenation and gas exchange. So we have to be thinking not only about these parts of the airway, but we also have to be thinking about the muscles and the bones and the connective tissues all at play here, right? The diaphragm, the intercostals, the pleura. It's not just the anatomy we're looking at here. When we talk about airway management, we're talking about the system as a whole. And any part of this system can fail. And a failure in any component of the respiratory system, whether that's upper airway, lower airway, or other mechanical and support functions, can lead to action and need to lead to action by you. So we do need to remember there is a difference between oxygenation and ventilation. It is commonly confused. Oxygenation is the actual delivery of oxygen into the lungs, passes through all of these structures we've already reviewed in order to get oxygen into the bloodstream. Ventilation is the act of breathing and gas exchange, the mechanics and the ability to not only deliver oxygen, but also to exhale the CO2 back into the world, which coincidentally also requires an unobstructed path, right? We'll talk a little bit tonight about SpO2 and end-tidal CO2. So remember, your pulse ox is going to tell you about kind of oxygen carrying capacity in the blood, and your end-tidal is telling you more about the ventilatory effectiveness. A person can have a normal SpO2 and be terribly hypoventilated. And similarly, a normal end tidal doesn't necessarily mean that they're oxygenating. So these two tools are very helpful to use together. Also, it's important to remember that from a pulse ox standpoint, those readings are delayed, whereas an end tidal reading is giving you information in real time. So when you're checking someone's pulse ox, that was what their oxygen saturation was 30 seconds to 2 or 3 minutes ago, depending on their perfusion and everything else. So you're looking backwards when you're using only SpO2. So end tidal is a really important tool to get very comfortable with. So if we're going back to our patient in the field, you're 38 minutes from a hospital without the right assessment and intervention. That's 38 minutes of carbon dioxide accumulation if you're not monitoring these things appropriately. Everything we do in airway management flows from assessment, right? From our assessment of the patient, not from your protocol, not from your drug box, but from what the patient is telling you continuously. So that means we need to know normal versus abnormal, right? Adequate breathing and red flags. Trust what you see. Your patient's going to tell you what you need to do. Maybe not with their words, but with their signs and symptoms and other objective findings. So keeping all of this anatomy in mind, we can move to our patient assessment. Remember, you gather a ton of information from just observing your patient. There may be calls where you walk in and there is nothing to worry about. And believe it or not, your subconscious is making the assessment as you are looking at the patient saying this is adequate breathing. But there may be calls within the first 5 to 15 seconds of meeting someone in this red flag box that require a very deliberate and very focused assessment. So you want to look before you touch, right? A 15-second visual and auditory assessment can tell you more than any monitor sometimes. So you're looking for accessory muscle use, this increased work of breathing. Is the patient compensating? Are they tiring out? Agitation and altered mental status. These are often signs of hypoxia, right? So when we think someone's just being mean and is agitated or combative, the other possibility is that they are not getting enough oxygen delivery to their brain. And that's an important thing for us to consider as we're managing our treatment out, as we're working through what our treatments are going to be, right? We don't want to give somebody a bunch of sedative medications if the reason they're altered is because they are hypoxic. So agitation, altered mental status can be early signs. If we think back to our rancher, he's GCS of 6 and unresponsive. There's a big difference between someone who has snoring respirations at a rate of 12 with equal chest rise and fall, or someone who has a GCS of 6 snoring respirations and agonal breathing, right? Agonal breathing isn't actually breathing, it's brainstem activity. That's just the brainstem. And so the approaches to those two situations may ultimately end up being different. Whereas your normal respiratory rate, Respiratory rate, really underrepresented vital signs when we're doing vital signs, okay? It really matters. It can tell you a ton about your patients. So actually count their respirations. Get a good number for that. All right. So with our second patient here, we've got a 34-year-old woman. She's a known peanut allergy. She was stung by a bee at a trailhead. She's anxious, she's wheezing, she has a hoarse voice and visible hives. You're 45 minutes from the nearest ED, and she's talking for now. So she's talking, but she's anxious, wheezing with a hoarse voice. Is her airway okay? Airway is closing. Yes. What is the trajectory of this airway, right? What direction are we going in? What's our decision point for intervening? We already see signs that there is potential for laryngeal edema. She has a hoarse voice, which may be telling us that in her, in her larynx, where her vocal cords are, she has potentially has some swelling. So you know this pathology, you know this story. We don't actually care that she has a peanut allergy and was stung by a bee. All that's telling you is that she has a history of potentially anaphylaxis, right? So you need to know that your assessment is a now and then what's going to happen. How is she now and how is she going to be in the next 10 minutes? All of us are taught ad nauseum to do an initial assessment, right? It's in every checklist. It's at the core of what we do. We're taught BSI, seen safe, how many patients, this initial assessment of your patient, ABCs, right? But your assessment of an airway is ongoing. It's not an initial and then reassessment. It's a continuous observation process. And then you have to take that information and adapt it to how it's changing and then use that to change your decision-making process, right? All of us are very good at the initial assessment. Our gap is in this reassessment and predicting space. One of the things that can help you in these contexts is documentation. And before you all throw tomatoes at your screen, I don't mean doing all of the paperwork right then and there, right? But it's how you kind of can see trends and notice a trend. And this works for some people and it may not work for others. But documenting somewhere in real time can help you actually process information. It helps your brain synthesize information to write things down, and it helps you adapt as you need to go. So sometimes our brains actually take shortcuts, right? They're going to be really good at pattern recognition, and they're going to help us take shortcuts. And how many of you have like recycled the vitals on somebody? And then 45 seconds later, you're going to put it in your chart and you're like, wait, what was that set? I just did it. I just recycled the blood pressure and I did all of the things. Or your partner told you the vitals as you're working on getting things out of your kit. And then you're like, sorry, what did you say the vitals were? This is normal. This doesn't mean you're defective. This just means that our brains get saturated and so they take shortcuts and they cut things out that they don't necessarily know are important at the time, right? So if we kind of apply this continuous concept to our anaphylaxis patient, we decided to give her epi because we knew where this was going. We're looking at her again. Is the stridor improving? Did it buy you time? Do you need to escalate? So a 45-minute transport means y'all have 9 at minimum reassessment cycles to complete for these patients, right? Has anybody and Pat Conroy, I see you're on screen, so I'm gonna pick on you. Have you ever changed your management plan mid-transport? Have you ever been like, oh, this is what this is, and then all of a sudden you're on a completely different trajectory? So, yeah. Yep, getting some yes, he goes off camera. It's like, don't pick on me. Yes, exactly. Thank you, Kelly. So yes, we change mid-transport, right? Especially when your transports are long. So, vocalize your airway assessment, talk to your patient, talk to your partner, and then be prepared to adapt and repeat this process. Look, listen, feel, and keep going. This isn't the checklist and then you're done. This is that ongoing loop. Stridor is a late sign of obstruction. If we hear stridor, we are already behind, right? absence of breath sounds on one side, pneumothorax or hemothorax, main stem intubation, right? Tracheal deviation. This can be a late finding too. Don't wait for that. Monitor your trends, not your numbers, right? Pulse ox of 94 in isolation doesn't tell me a ton, but a pulse ox that goes from 94 to 90 to 88 tells me more. That tells me that we're on a trajectory that we need to intervene on. So you see the pulse ox of 94, you may not be like, oh, I need to put this person on oxygen. But if you see a pulse ox that's 94 and then 90, you need to start getting things unpacked, right? So the patient who's fighting and looking at you funny, there's a very good chance that they're telling you the direction that they're going. So we want to anticipate deterioration. I don't want you all to be afraid of these patients, but I want you to be prepared for the worst case scenario, right? Hope for the best, but plan for the worst. Get your stuff ready if you need it. You don't want to be digging through the cabinets when you're trying to find your CPAP machine, right? So identify your decision triggers. If X happens, I will do Y. This is a really helpful exercise to do with your partner, either during the call or just vocalizing it to them, or even en route to the call. We do this in the emergency department all the time. We say, hey, all right, here's the thing. If this patient starts to get sleepy, then I'm prepared to intubate. Right? Patients that tire out. If this CT scan comes back negative, then I'm gonna do an ultrasound. Like you have these if-then plans, and if you say them out loud, then when that happens, you're not surprised and you're not like, oh shoot, what was I supposed to be doing? So communicate with your partner early, call for help early. The person who says, oh man, I didn't think it was going to get that bad, was underprepared for what it was, right? Pre-planning is your backup team, right? If I start to notice I can't get their SAT above 89 with all these interventions, we should call for an ALS intercept, right? So these are all things that are going to play into your decisions. Yes, if the patient is going to vomit, I'm going to aim it at my partner. Exactly right, Jason. That is exactly right. If they're throwing up, I'm turning their head towards somebody else. Well played, sir. All right. So, basic airway adjuncts and BVM, right? These are our most important tools for every level. We are assessing our patients. We are ready to intervene. These are two skills you just need to have down pat. We're going to spend a little time here because these skills save more lives than any advanced airway does, right? An excellent BVM technique with a good seal is superior than a rushed, sloppy attempt at a tube. I wish I could tell you that there was a slam dunk study and slam dunk evidence that says when to do a BLS airway, when to consider an advanced airway, when to do a BLS all the way in on your transport, but it can't be that simple, right? And it's not that simple. And so what I can tell you is that when all else fails, this is what you will be falling back on. So you have to be outstanding at these interventions, no matter what level you are as a provider. That means every shift, when you come on shift, or every 24-hour cycle, practice these skills. These are the ones to practice every chance you get, every downtime, so they're second nature to you. Are they going to fix every situation? No. But are they a very solid foundation that could potentially save your patient's life? Yes. The clearest recommendations that we have for BLS versus ALS airway in that eternal debate, and almost all of this comes from cardiac arrest literature, right? When you're deciding what to do in your awake-ish, deteriorating sick patient, there's no study that can encompass all of the confounding elements of those patients. But in patients that are in cardiac arrest, we can try to see what is best. But the first sentence highlighted here really sums it all up and should be applied to every aspect when you're talking about EMS and airway management, which is know your strengths and limitations, right? Based on the skill of the clinician, and the available resources. Based on the skill of the clinician and the available resources, BVM, SGA, which is supraglottic airway, or ETI, endotracheal intubation, may be considered as airway management strategies in out-of-hospital cardiac arrest. This is from the position statement from NAEMSP. And all of the research we have hinges on this caveat. It's the skill level of the provider, of the clinician, and the resources available. So know what you're good at and know your weak spots, right? This is going to become a key part in your decision making. Dr. Farkas and I work clinically at a teaching hospital, and we are constantly faced with this exact same question and situations on a daily basis. We have to balance, education, which means helping someone get more comfortable in these challenging airway situations, allowing them to work on their skills with what is the safest option for the patient. So, there are airway management scenarios where I will simply say, I am sorry. This is an attending airway. Based on my assessment of the patient and my experience, it's too risky to allow anybody else to try this because I know that that's a strength that I have, and I've been doing this for a very, very long time at this point and can have done hundreds of intubations. There are other situations where I will say, get up there and bag the patient. Let's see how they do. I want to see your BVM seal, and I want to see your ability to appropriately bag a patient, and then we can talk about intubation if we end up there. So know what you're good at, and in the worst case scenarios, go back to what you're good at. Okay, so what about a 42-year-old patient who is postictal after a witnessed generalized seizure? GCS is 8, airways full of vomit, respirations are slow and shallow at 8 breaths per minute. He's not quite protecting his airway, and you're 20 minutes away from the hospital. What's our first action here? Suction. Yes. Suction, 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 suction. Love it. Before anything else, the airway's got to be clear, right? At a GCS of 8 and he's postictal, he may not have airway reflexes anymore. Are we going to do an OPA or an NPA on this patient? Is a BVM appropriate here? What's the risk of BVM in a patient who has an airway full of vomit, right? Or does this patient need an advanced airway? We don't know enough yet. But we do know we've got some great tools, and we should not look down upon our OPAs and our MPAs. Our OPAs, oropharyngeal airways, remember the corner of the mouth to the earlobe. I was taught to insert inverted, rotated 180 degrees. You can also do 90 degrees. I think the idea is like don't scratch the entire soft or the entire palate on your way down. It's still advised not to insert these straight away, although I know some programs are starting to teach that because it's going to push that tongue back. The only time you can use an OPA is if your patient does not have a gag reflex. If you try to use an OPA and your patient has a gag reflex, you just made your situation worse. Sometimes the only way to figure out if your patient has a gag reflex is to try to insert an OPA. So if you think you need it, give it a try. Holds the tongue off the posterior pharynx, and again, if they have a gag reflex, you will find out shortly. The nasopharyngeal airway or the NPA, lubricate these well, please. They can be tolerated in semi-conscious patients. If you really, really think they have a basilar skull fracture, don't put this in. And when they have a gag reflex, that's the preferred adjunct. Anatomy is important, and that's why these pictures are in here, and that's why we visualize the anatomy. You should know what these adjuncts are doing. So you can see the OPA there on the left is working to create that tunnel, for lack of a better word, for oxygen to go from the outside world to the inside world, and it's moving the tongue out of the way. So the oxygen is going to be able to pass more directly into the lower airways. The NPA helps a bit, right? Especially, you can see in this picture, it's not going to move the tongue out of the way, but it does, if you size it appropriately, it at least gives the oxygen that you're delivering a little more of kind of like a jet streamed route to the lower airways. So choose your adjuncts wisely should they be needed in your patient. And then there's your BVM, right? Two-person technique is almost always preferred, right? If you've got a firefighter or a law enforcement officer or someone else who has been trained, take hands to get a good seal. So you can do the EC that we learn, or you can, if you have multiple people, that's gonna be your best bet. You want to do this in conjunction with some potential airway manipulation, right? Remember, the person laying flat on their back, and I go back to this picture just to show us the anatomy, and maybe looking at the NPA one is helpful. If you're BVMing, the person laying flat on their back, you need to create a route for the oxygen to get down. So you may need to manipulate the airway a little bit. The most common error in BVM is too much, too fast, and trying to get the entire bag in. That's going to really lead to insufflation of the stomach or getting all that air into the stomach. That's going to increase their aspiration risk. So try the chest rise only approach. If you see the abdomen rising, you're ventilating the stomach. We don't want to do that. So you really want to be squeezing enough in, not a full squeeze, that the chest rises. And so that's usually 500 to 600 mLs. Hopefully, I think a lot of agencies were switching the size of their bag and I think a lot of the literature has shown us that we were kind of overdoing it on the BVM. So maybe you guys have moved to some of the smaller bags. So for our postictal patient, maybe some gentle BVMing with an NPA in place after we've suctioned to monitor these patients for improvement or deterioration. If you have a BVM handy, you can go get it and practice while we're on this lecture. All right, the most important part of the BVM is the seal. Also, look at this cute picture of a seal. So most important part of the BVM is getting that seal. It's not going to do you a whole lot of good to squirt a bunch of oxygen into the world around you, right? So make sure you're getting a good seal that's best done with two people. Smaller bags, yes, they're great for the smaller hands. Exactly. It helps you make sure that you're delivering the appropriate amount of oxygen and technically makes it more reasonable for people that have smaller hands. And the most important part is the seal. All right, we have other ways to deliver oxygen, right? So remember, oxygenation and ventilation. So you've got your nasal cannula, your simple face masks. Some agencies are carrying these, some are not. This is all we have in the hospital. It's interesting. You've got your non-rebreathers, right? Your BVMs with the reservoir, and then apneic oxygenation. Apneic oxygenation is really, really important. I cannot emphasize this enough. If you know or anticipate, because you're anticipating things, that your patient is going to likely end up with an advanced airway, be that a supraglottic or an endotracheal tube, put them on oxygen immediately. Put a nasal cannula on and turn it up. Put a non-rebreather on if you can. The concept of apneic oxygenation is we're essentially flooding the lungs as best we can, so that we have more reserve when we intubate. If you're a BLS crew that's waiting on an ALS intercept, or you're a BLS crew that's waiting on a helicopter, get them on if you'll start to recognize who's going to need to be intubated. You know why you called the ALS intercept. Get them on oxygen early so that the person doing the procedure has as much opportunity for reserve as they can, right? So these are things that we want you to be pretty aggressive with. The days of putting everybody on 4 liters nasal cannula that even blinks 6 times instead of 7 is those days are over. But the idea of making sure you're setting yourself or your partner or your crews up for success down the road is really, really important. So a well-placed NPA and a perfect BVM seal beats a rushed advanced airway every single time, right? So you can't unintubate, I mean, you technically can extubate somebody in the field, but you probably shouldn't. But if you start a tube and you're not confident, you don't have things set up, you can damage the airway and significantly make things worse, right? You can induce vomiting, you can cause hypoxia, you can cause soft tissue swelling. You can cause bleeding. So the decision to escalate to an advanced airway is irreversible in a lot of ways, right? So a well-placed NPA and a perfect BVM seal, of course, depending on some of the whole clinical situation, will get you where you need to go a lot of the time. All right. Any questions about airway adjuncts, BVM, oxygenation, and oxygen delivery? And I'm going to take a sip of water and see if anything pops up in the chat. Not seeing any questions. Okie doke. We shall. Thank you, Jason, for the seal. I want to know how long it took you to find that emoji. All right, we will dive into advanced airways. Advanced airways are powerful tools, and like all powerful things, they can cause serious harm when they are misused. So, we are going to use them when basic maneuvers are insufficient. We are not using advanced airways as a default. So we've got a 54-year-old male patient who's unresponsive after a suspected opioid overdose. Narcan times 2 with minimal response. BVM ventilations are difficult. He's got a bunch of facial hair, so you're having a really hard time getting that seal. And your pulse ox is hovering right around 88% despite 15 liters per minute, and you're 50 minutes out from the hospital. Okay. Well, two-person BVM is failing. So at what SpO2 are we going to escalate? What's our number going to be? At what point are you going to be like, all right, we're going to keep doing this if we're hanging at 88, but if we go below X, we need to do something else. I'm assuming everyone's just thinking it in their head. So most people have a number that they're comfortable with. Get the chest hair razor out and get rid of the beard. Alan, that's a great suggestion. I love that idea. Get a good seal. Do things, tips and tricks to try to get that seal better. OPA right away, not waiting. We're not waiting for it to go lower than 88 because we're already at 88. We're already low, and we did not make any progress with Narcan. Anything below 90. Intact gag reflex. We'll say no. You put the OPA in and there's no gag. Put the plastic bag from the ambu bag over his face and poke a hole to bag it through. So kind of improving that facial hair situation by getting another seal. I like it. I guess you'd have to have two ambu bags to do that because you just broke the one. But hopefully you have two on the rig. And we don't want to tube him if he's going to reverse, exactly. So we commit to an endotracheal tube, but maybe the Narcan does start to kick in, or maybe we give him a third dose. So these are exactly the questions and exactly the kind of situations where you're thinking through the process. You're saying, well, is he going to continue to decline? Is he going to go 88 to 85 and then we're going to do something? Are we going to wait till he gets to 80? Or is he going to go 88 to 92 and that Narcan actually works? But we tried Narcan and he had minimal response. So exactly, these are the things that you should be thinking, and these are the decisions you're making in your head. So what I would encourage you to do is get things ready. Exactly, Jason, and everybody in the chat, get things ready for things to get worse and figure out what your threshold is going to be. Does anybody still have King LTs? I put it in here because some people do. There's a few out there that are still lingering. Yep. See, there we go. King LTs. Glad I put it in here. So these are supraglottic airways, right? In the eye gel is in the Colorado EMT basic scope. It's also in many EMR groups are allowed to use an eye gel. I think less folks from the EMT level are trained in King LTs, but if you are and it's in your scope as set by your medical director, supraglottic airways are a really important tool. Know this tool, practice this tool. Don't wait for a paramedic to show up before you use this tool if you know and have been trained on how to do it, right? For both of these devices, confirmation is mandatory, right? It's very it's hard to do the eye gel wrong. You can do a King LT wrong. But the most common supraglottic airway error is not going deep enough, right? So you're going to enter the airway to resistance. Don't stop early, and it's okay if you meet a little resistance to advance a little bit further. Um, if you overinflate the King LT cuff, can you cause necrosis potentially, but just use the recommended volume. And then make sure you secure the device, right? Secure the device, secure the device, secure the device. So this is a visualization of these two different supraglottic airway devices. And again, this is why understanding anatomy is so important, because you want to be able to kind of visualize what you're doing. So with those eye gels, lubricate it well, and then be prepared, of course, to secure, and then you can oxygenate and ventilate the patient through this device. And the gold standard for placement and adequate ventilation is waveform capnography. There's no reason not to use waveform capnography, and I have to talk about it because this is an airway management lecture, right? After any advanced airway is placed in EMS, the pulse ox alone is not going to get you enough information. So if you've been trained on this and this is in your scope, please, please, please practice and know your equipment to be able to use capnography. It's going to help you know that your tube is in the right place. It's going to help you identify if your tube has been dislodged or if your patient is peri-arrest earlier than any other thing that we have, okay? So you should have a nice square wave with a supraglottic in, if it's a completely flat line, either your equipment's not working, the patient has completely died, or the device has been placed only in the esophagus, so you may try to pull it back a little bit. And then again, as I feel like a broken record, it's the trends, right? If it's rising, if that end tidal is rising, if that number is going up, we're probably hypoventilating, depending on what your starting number was. If it's falling, we're hyperventilating, or maybe we have decreased perfusion. And in cardiac arrest, if you've got this patient that you're working in a cardiac arrest and you have a supraglottic airway in and your end tidal from the beginning is 10 and then all of a sudden it spikes to 40, it's very likely that you just got ROSC. So really cool. This is often our first sign of return of circulation. So end tidal is your numeric continuous monitor and reassessment tool in these patients. I put almost everybody on end tidal in the emergency department because it just tells us so much information. And it can be very, very useful in helping us with trends and predicted outcomes. All right, just waiting for someone to make a decision. As with many things in medicine, sometimes the hardest part and sometimes anything about airway management is recognizing and deciding that you just need to do something about it, right? And this is traditionally what we say about the crike. The hardest part is making the decision to crike somebody. But truthfully, that's the case for all aspects of airway management. I hope by the end of this, you feel more comfortable with things and the tools you have in your toolbox that will make that decision a little bit easier. Okay, so when and how are we making this decision? I'm going to show you a little bit about the things that I think about and then a little bit about the things that I want you to think about. We're going to go through the different aspects of airway management in kind of this decision-making process. Yes, exactly right. Chief Conroy, part of anticipating the worst is having enough hands. Bring people with you. If you think they're going to go south, get extra bodies in the rig. So if we're going to need to intubate a patient, what are some of the things we think about, right? Do I need to overcome a mechanical obstruction? Remember that upper airway part, or sometimes even the lower airways. Is there a mechanical obstruction I need to overcome? Are they inadequately oxygenating or ventilating? Do I need to do this for neuroprotection? Do I know, their anticipated clinical course because of their massive stroke or brain bleed or status epilepticus that I need to treat with crazy doses of things? Sometimes it's the kind thing to do, right? What does that mean? Like, if I need to achieve a certain level of pain control for a patient that I simply cannot get while keeping them awake, there are circumstances in which that would be the reason we need to intubate. And then this acronym that everybody loves, which is like GCS of less than 8 intubate, but it's not quite that simple. What are we taught in the field? Overcome mechanical obstruction. Great, perfect, check. Oxygenation and ventilation. Great, we went over that. Airway protection. That's on both sides. This is my least favorite reason to intubate somebody because, like, what does that actually mean? It kind of seems to be this catch-all that we use when we just know we need to intubate the patient, but we can't necessarily articulate why, right? We say, oh, we need to protect their airway. From what? From a mechanical obstruction, from, pathology, such as, end-stage COPD that's made it significantly worse, which you could argue is a mechanical obstruction, because they're continuously vomiting. Like the airway protection, I want you to do the mental exercise of taking that one step further instead of just saying, oh, their GCS is less than 8, we need to protect their airway. Um, as far as I'm concerned, this term doesn't even need to exist because you can always come up with the actual reason that you need to intubate the patient. And then safe transport. And this is something that you all, especially in the rural setting, if the helicopter's coming or that you've got a really long time to go and or it's an interfacility transport. I think a lot of folks on here probably do a lot of IFTs. There will be patients that when you go to pick them up in the hospital, you're going to do your own airway assessment, right? You're not just going to take report and leave. So you'll do your own airway assessment. And then you'll say, hey, I think we really, based on my anticipated trajectory for this patient, because I'm thinking through all of those things, because I'm such a good clinician, I really think we need to intubate this patient before we get in the back of the rig. So, something also to keep in mind. Oh, didn't mean to animate that slide. All right. So, endotracheal intubation, right? This is what we think of as the gold standard for definitive airways, but this is also the skill that has the highest skill decay rate and the highest complication rate, right? So, this is a paramedic level skill in Colorado, but all providers benefit from understanding this process, especially when you're assisting. There's all sorts of acronyms and things that you can do to remember all of the steps. Um, this is one that, is out there. It's not my favorite, but and EMTI, sorry. Yes, Dr. Farkas and EMTI. Thank you. Um, Pre-oxygenate patients, right? So we talked about this, that apneic oxygenation, budget your apnea time, give yourself time. If you fail twice, it's the airway is now becoming increasingly traumatized and swollen, so you're going to have to pivot. You're going to have to pivot to a supraglottic or something else. But if you're trying to, intubate somebody in the back of an ambulance and you're moving down a dark road, that's significantly harder than doing it on the sim mannequin in your station over and over again. So, because of the degree of skills atrophy here, it's important that you practice not only the muscle memory of putting the tube through the cords, but the muscle memory of all of the steps leading up to it and all of the steps after you put the tube through the cords, right? So, pre-oxygenation, suction, C-spine considerations, anticipate your barriers, have your backup plans, have your equipment out. This is also part of the practice to try to increase your training and have you set up for more success, right? So pre-oxygenate, like I said, immediately. That's something that we can all do. Put on a, nasal cannula, non-rebreather. You want to get as much in as possible. Make sure you're ready to go with suction. That's going to be your best friend. And then have backup plans. Have a bougie, have a smaller tube, have your cric kit if you think that that's the direction you're going. Um, and then get ready to do the plastic through the cords. If this is something you are authorized to do and credentialed to do and you haven't done in a while, do 4 or 5 reps on a mannequin at the station and then take that mannequin somewhere challenging and do another 4 or 5 reps. And then take that mannequin somewhere else and do another 4 or 5 reps. You want to be stressing your simulation to mirror the amount of stress that you would have in an actual situation. Try to make it real, right? Once you get comfortable just on that table, then go into a different part of the station and put on really loud music or sirens or screaming or have your partner come yell in your face while you're trying to get this in. Really try to work on the realism piece so that your nervous system and your subconscious knows how to focus on this procedure while there are other things distracting you. All right. There's lots of different ways to intubate a patient, right? Each of them have their advantages and their disadvantages and considerations in trauma and things like that. This table was adapted from Life in the Fast Lane, which is a really great resource. So DL is direct laryngoscopy, so that's not a video. It's fast, it's available, it's operator dependent. So this is something that you would have had to be trained on and that you have done a bunch over and over and over again. MILS is manual inline stabilization, i.e., you're trying to protect the C-spine. This makes it more challenging if you're doing direct laryngoscopy. VL is video, and that's less mouth opening is required. So this can be a little bit easier if you're in a trying to protect the C-spine. Some devices you can do either or, but videos can get obstructed. Their batteries can die. There can be blood or secretions that can make it so that you can't see. And it's unknown in the field, especially which of these is better. As a medical director, we really do prefer the video laryngoscopes because then we get to watch and help. Sorry, I need to yell. I'm not going to yell. I'm just going to tell my dog to hush. Hold on. We prefer to be able to rewatch the videos and be able to give coaching and all of that. Awake fiber optic intubation is a luxury we have in the emergency department that is not in the field. It's not always ideal, but for the perfect patient, it can be useful. And then we already talked about supraglottic airways. They're fast. They're sometimes better than a BVM. And we think of them as a rescue device, but sometimes it should just be what you go to. It should just be what you pull. Okay. So, bringing us back to this philosophy, the right airway device is the one that is working right now for what you need, right? So, reassess after every intervention. If you can't get the tube, it's not worth repeatedly traumatizing the airway. The goal is oxygenation and ventilation. The goal is not device success placement, right? So after you place something, are you done with airway management? No, that what's working right now may not continue working, but it is something that you need to be making sure it is continuing to work as you go forward. Okay. Not seeing any questions. I'm going to keep flying through. So we've got and reassessment. Yep. Every few minutes, continuous if it were up to me. Rural specific considerations for the failed airway when things don't go as planned, and they never will, right? You have to have this higher standard of preparation because you have a lower margin of error. So you've attempted intubation twice on a 67-year-old cardiac arrest patient. They have a difficult airway. They have a short neck, beard, limited mouth opening. The SpO2 is continuing to fall. You're 40 minutes from the ED. Your partner is driving. Looks like we decided to transport, but you've missed twice. So now what has happened to the airway after we've missed this intubation attempt 2 times? It's swollen and it's angry. And we're not oxygenating. Yep, swelling and trauma. So what are some options? What can we do in this circumstance? NPA, iGel, great. OPA, BVM, P A, B V M, 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 Perfect. Okay. So you all are charged with this not small feat of managing airways with limited resources. Know your equipment before the call. No surprises. Nobody wants surprises in the field, right? So know where your stuff is, know what you need. Equipment familiarity is a pre-shift responsibility. Um, Get ready. Like we talk about staging and we think about staging as far as like staging an ambulance until the scene is safe. Yes. And have your escalation plan ready before the first attempt. If you are going to attempt to intubate the patient, have your supraglottic airway out. Have your OPA and BVM available, right? You don't have to open it, but it should be right there. Clear assignments prevents confusion in critical moments. You should set your partner roles prior to doing anything, right? Early communication with each other is really helpful, as is early contact with medical direction at the receiving facility or air transport. If you know your regional criteria, sometimes you need to just launch a helicopter because you know the direction that it's going. If you've got an airway that's going to be difficult and you're 45 minutes out, then maybe start looking at a helicopter intercept is faster than you repeatedly traumatizing the airway as you bounce down the road, right? But I recognize we cannot always fly. So if you've failed more than 2 times or you can't oxygenate with a BVM, call for help. ALS, intercept, air transport, another rig, call the ED and let them know. Call somebody. Somebody needs to know. Somebody is besides the two of you need to know that things are not going well. And you can have your partner call if they're driving. While you're trying to do some of your rescue maneuvers in the back. Again, optimize that BVM. If you can't, if we failed twice and we're going to BVM, 2 person, get that seal, put in airway adjuncts, consider that supraglottic. And then, of course, what we haven't covered yet, which is the surgical airway. The threshold is clear. We've talked about, the nice little saying is you can't intubate and you can't oxygenate and your supraglottic failed. Maybe you're considering a surgical airway, your cricothyroidotomy. Can't intubate, can't oxygenate. Last resort, but no hesitation, right? So this is a life-saving procedure and it is rarely needed. It is the last resort, but if you make the decision, then you commit and you go for it and you do it right. So you've got, I'll show a picture here in a second. I think most people are doing surgical at this point in the field. I don't know if anybody has a needle crike kit that they're using. It really depends on what folks buy, but all you need to do a crike is a bougie and a scalpel and a tube. And some people teach, this is very regional. We learned recently, the group of medical directors where we were working on the protocol updates, and even amongst like the 3 of us at CU, we all do a crike a little bit differently. So just figure out what works and commit to that style for yourself and practice, 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 practice. Um, and say it out loud, right? So when we talk about kind of that conditioning, we're saying, okay, I'm going to attempt to intubate this patient. If I can't get this tube after 2 tries, I'm going to move to a surgical airway. Say that out loud. Tell that to your team, right? Be ready to take that next step and know that, and then your team knows what your next move is, and they can have equipment ready and all of that, right? So here's just a little landmark cool picture, which is you've got your thyroid cartilage, your cricothyroid membrane spelled wrong, and then your cricoid cartilage there as well. And you're going to want to cut the skin. Remember, that's going to be a vertical incision and then probably a horizontal punch incision through the cricothyroid membrane after that. All right. I'm guessing that many of you have air transport handoffs and communications. You know, you have what your standard handoff is. A proper handoff is the last act of airway management, right? This is part of managing the airway, communicating with the rest of the people what you did for the airway. You can do an SBAR, you can do a MIST, you can do whatever works for you, but it's really important to communicate the device, the depth, the confirmation method, and the trend reports. Part of the reason is that this tells us so much, whether you're giving us the handoff in the hospital or you're giving us the handoff to the flight crew or to the ALS intercept. He was at 95%. Now he's at 91%. I've tried to bag him faster, but I noticed that his end title has changed. I'm concerned about the placement of the tube. Really knowing the trajectories and the trends is going to help you communicate, and it's going to help that person anticipate what they need to do next. Documentation, document every attempt, every device, every medication that you give in the timeline. It is very, very helpful, right? Successfully intubated on first attempt, successfully intubated on third attempt, had to switch to a lower size tube. Whatever it is, just write it down. There's no shame here. This is hard. This is hard for all of us, right? So write it down. There's no embarrassment or shame, but it's a lot easier from like a QI review and from a training and education perspective if we're reviewing charts and we notice that every OPA results in ultimately a supraglottic insertion, then maybe we're not doing OPAs right, or maybe we need to look at the devices we have, right? So it helps us and it tells us a lot about what we need to do as a system to set you all up for success going forward. All right, there's some special populations we need to consider. Same principles, different anatomy. You're dispatched back to back. First, a 4-year-old drowning victim pulled from a pond, unresponsive, bradycardic. Then a 310-pound male with a C-collar on who's entrapped after a rollover. Your airway approach to these two patients is going to be very different, right? Kids are, you knew I was going to say it, not just small adults. And I will be totally honest, and I know this meeting is recorded, but I'm going to say it anyway. The majority of the time, kids are small adults. However, airway anatomy is an exception to that. Kids are not small adults when it comes to the airway. They have different anatomy, right? They have the large occiput, the large back part of their head, which means when they're just laying on their back, their chin is down and they can obstruct their airway. Their larynx is more anterior and superior, so it's harder to see. The epiglottis is floppy. It is the floppiest, most obstructive, obnoxious thing in the airway. Everything is smaller, which means secretions are going to obstruct faster, and their little hypermetabolic bodies eat up oxygen quicker, so they desaturate more rapidly. So you need to adjust your approach, right? You need to do things a little bit differently. Shoulder rolls can help. You need to use an uncuffed tube or a lower pressure cuffed tube. BVM size matters. So how much you're pushing into their lungs for the BVM really does matter. And bradycardia or cardiac arrest in children is hypoxia or respiratory until proven otherwise, right? So keep that in mind. Cardiac arrest, pediatric arrest and assessment triangle, airway, airway, airway. What about traumatic airways? We want to protect the spine without losing the airway, right? C-spine precautions are important, but a dead patient doesn't benefit from a C-collar. So, you got to do some hard decisions sometimes. If you need to insert an advanced airway, undo the C-collar and have somebody hold manual inline stabilization. That will allow you to get more facial movement of the lower mandible, which will set you up for success. Don't apply traction. You all know that. The C-collar reduces, it's not only the fact that you can't put them in the sniffing position, but it reduces their mouth opening. So again, having somebody hold their neck mechanically so you can take advantage of the mouth opening is good. And then, of course, blood, secretions, facial trauma, suction, suction, suction. And then your jaw thrust in trauma is preferred over the head tilt and the chin lift. All right. So, what are some considerations for this guy's airway? Our inclination when we get onto a scene with any patient is to put them on our cot and lay them flat. What's going to happen when we do that to this guy? who's in an OR and not on the side of the road, but still. Yeah, aspirate, blood, teeth, airway obstruction, right? Um, let patients manage their own airway if they can do so safely. Sometimes less is more. Sometimes you need to do nothing. You need to let somebody sit up and you need to let them, I think of like a post tonsillectomy bleed. Let them sit up and lean forward and just continue to spit all of the blood out into the vomit bag or whatever it is that you have. Because laying people flat and doing a bunch of things can set us up to fail sometimes. And that's especially true with trauma. Other unique patient populations, some considerations for obese patients and difficult airways. Positioning is everything, so consider not laying these patients completely flat. Put the whole head of the cot up. That helps not only with visualization if you're doing an advanced airway, but if you're doing like a BVM and an OPA or an NPA, if someone is morbidly obese, you're going to want to sit the bed up a little bit because that's going to allow the mechanics of ventilation to work in your favor. You're using gravity to move some of that soft tissue to be able to allow them to ventilate a little bit better. Again, pre-oxygenation is crucial. Your functional reserve is reduced. Your desaturation is going to happen so fast. Anticipate that difficult seal. And then often edema will accumulate more rapidly here. So just know some of those things ahead of time. Know your patient before you know your plan, right? Recognize your challenges in anatomy. Recognize that your anatomy may change the approach, but all of these concepts remain the same. Okay, we have a few minutes to do a few cases. And this is a lot more fun if you guys put things in the chat. So, 71-year-old male with COPD exacerbation. He's sitting in the tripod position. His SpO2 is 82% on home oxygen. His respiratory rate is 32. He's using every accessory muscle that you can see. He's confused, and he lives 55 minutes from the emergency department. And his wife says, he was fine this morning. I do not know what happened. So, what is our immediate airway and oxygenation intervention? Anybody? BVM? BVM, high flow, duoneb, duoneb, and CPAP. CPAP, love it. Love to see some CPAP. All right, so this is a patient that needs very early intervention, right? And I see a lot of CPAPs in the chat, and that's great. You have a lot of information already with just this very short scenario, right? COPD, he's in a tripod position. He's got a respiratory rate of 32, and he's using every accessory muscle you have. Yes, of course you need more information, but you also have enough information already to start setting things up and to get going, right? So you may have different ventilatory targets in someone who lives with COPD. Don't be surprised if those end tidal numbers are way off of what you're used to. And then know that these patients will get tired. And we say that a lot. And what does that mean? If somebody's respiratory rate is 32 and then they get a little sleepier and then their respiratory rate is 20 and then their respiratory rate is 12, you're like, oh, well, a 12 to 20 is a normal respiratory rate. Not for this guy, right? This guy needs that rate of 32. And as soon as you start to see him slowing down, you know he's getting tired and you know something's going to change, right? So then you're thinking about that GCS changing, his respiratory rate is decreasing. Is that technically an in-range normal number? Yes. But in the context of your reassessment, you know you're going to need to move, right? So you're going to probably need to look at BVM support at that point or versus continuing on CPAP, depending on what his mental status is. Positioning is everything for our non-invasive positive pressure ventilation or CPAP for the folks on this call. Don't lay somebody flat and then put them on CPAP, please. Please sit them up. And then additionally, here's some fun little tidbits for it, right? So, pulmonary edema, it's great. Data tells us it dramatically, dramatically reduces the intubation rate in patients that have pulmonary edema if we put them on early non-invasive positive pressure ventilation. Helps in COPD, decreases work of breathing. May help in asthma. There's a few studies out there we know it doesn't hurt in asthma. We don't have nearly as robust of literature to say like it decreases intubation and all of that. But it doesn't. We know that people don't do worse necessarily with it. It can help with pneumonia, and then again, flash pulmonary edema. Sorry for the British spelling on that one. I was getting a little tired. Um, so don't wait for these patients to deteriorate. If you have signs that these patients need early positive pressure ventilation, get them on the CPAP. When you aren't going to use it, maybe don't use it in cardiac arrest. We did a trial in the hospital looking at pre-oxygenation with it. It was super interesting, but it made us all very nervous. If somebody's actively vomiting, obviously, if they can't protect their airway, there's our favorite term. Significant trauma, burns, a pneumothorax is going to be significantly worsened by positive pressure. And then if somebody is pretty like labile or hemodynamically unstable. So it can reduce their preload and ultimately worsen their blood pressure. All right. Scenario number two, you've got a 28-year-old female who is the unrestrained driver in a high-speed MVC. She has a GCS of 10, mid-face instability on palpation, and bilateral periorbital ecchymosis. She has blood visible to the oropharynx, a pulse ox of 94. C-collar is in place, and she's 30 minutes from a trauma center. So, what are some of the interesting things we're thinking about here? What does the mid-face instability tell you about what intubating her is going to be like? Interestingly, sometimes we think that facial trauma makes intubation harder, and often it can. But if it's just the face, sometimes it makes it easier because you can lift the whole face off and get a great view of the airway. Now, if there's blood and teeth and secretions everywhere, then it definitely does make it harder. And then again, looking at these trajectories, she's got a GCS of 10 for right now. But if you have two failed intubation attempts and now her pulse ox is 89, where are we going next? Assuming we're an ALS crew, we're going to be criking, right? And we need to tell the team we're coming. All right. I think we're going to call it there because I want to leave a little bit of time for questions. And I just talked for a very long time. So let's, things that I want you to take away from this. Airway management is dynamic. It's all assessment driven and procedure second. It's assessment first, procedure second. Okay. Always reassess continuously. Is it better? Is it worse or the same? At what rate? It's not just a device or tube through the cords. The best airway is the one that's working right now, not the coolest and shiniest and most impressive. Know how to use your supraglottics, stage your equipment before your call, and communicate early. Talk to your partner, talk to your patient, talk to the receiving facility, right? You are always managing the airway. Even when nothing is wrong, you're watching it to make sure that it stays that way. So, with that, looks like the great Dr. Farkas put the link for, and then she's gonna share the QR code, I imagine, which is probably why she
Yes,
took a, yeah.
thank you for sharing. It's up.
Perfect. QR code, make sure you get your CEs. Tis the season for recertification, so make sure you fill that out, get your CEs, and I will hang out. If anybody has any questions, feel free to raise your hand, unmute, or throw them in the chat.